Hi, everyone. Here we are. This is the first ever Ask the Testosteronologist. My name is Dr. Thomas O'Connor. For all of you that are not aware of who I am, I've been in this field of testosteronology and health awareness and harm reduction for anabolic steroid users, and an expert in testosterone replacement for many years, maybe 20 years now, over 20 years. So at this point, we are ready to bring together what I've created, and I'm here to help more people that are, again, on testosterone itself, including men and women that are using testosterone for therapeutic purposes. And of course, we always have the harm reduction side of anabolic steroid users. And that's what I really want to work on. And of course, something new that's really not new for me is that there's a lot of teenagers, adolescents using anabolic steroids and SARMs and peptides and all these type of agents, and that's not cool, right? So we have to work on that. I'm going to work with the parents, and I want to work with the guys themselves, because I don't want to ever, you have to be careful, right? We don't want to be too foreboding, and we don't want to be too aggressive, because it's just not going to work, right? Because these guys are using these agents. But how do we work around that? What do we do on this? I have to be very careful. So the first thing I want to do on this, I'm going to present something, testosterone delivery. I'm going to present to you today all the testosterone formulations that we have in the world. And you can get all this, by the way, on the Testosteronology Health Portal, and for the healthcare providers that we're training, the Testosteronology Society. And I want you to understand that you're going to ask your questions after I run my presentation here. You want to go to testosteronology.com /stage, right? So go backstage. Mark is my technical guy. Mark, we're going to put that up here for everyone. So you guys, I want to answer your questions. So you have to be able to access questions. Can we get that up? Right there. There it is. Just keep that right there, Mark. So that's where you go, and you will be led into how you could ask your questions. So as you guys are figuring that out and you're getting your questions ready, let's go. So Testosteronology Society that I've created has put together a lot of guidelines and advanced clinical practice guidelines, in addition to videos that we have to teach people exactly how to take care of people from diagnosis through management of testosterone deficiencies, legitimate, including women, of course. And of course, there's a harm reduction standpoint, right, for the steroid guys. So there's a big business now. It's unfortunately tens and millions of people, which is great, that are going to be on testosterone, but we have to have proper medical support for it. And just endocrinology and urology and even internal medicine and primary care is not enough. And certainly the health coaches are not enough. But again, if you health coaches are trying to do the best you can because you're working in a vacuum, you need to come work together with us, because this is real medicine. It's real medicine to understand the complications, what's going to happen when you're on testosterone and steroids. So let's talk about testosterone. Well, testosterone delivery mechanisms have really initially been worked out almost 100 years ago, in the 1930s, when we first discovered testosterone, right over in Europe, and through the developmental periods from the 1930s through the 1960s and into the 70s. That was really the heyday of the formulations of testosterone and derivatives of anabolic steroids, in which there's three types: testosterone derived, DHT derived, and nandrolone derived. Now, all the bro science guys know this, but a lot of doctors don't know this, but we're going to teach it. So, but of testosterone, real medical formulations, let's talk about it. Here's what we have. We have, first off, we have the injections. So, and these, of all the formulations, are the most common and most utilized. This spans the world, right? Because my scope is really a world scope now. So if you look at the most common formulation of testosterone, it's the injections. Okay, we're going to go into the creams and the pellets and the oral. Hold on. Number one, testosterone cypionate, depot testosterone, old school, and then we have testosterone enanthate. Let me go into this a little bit. And again, the bro science guys and the coaches and all the steroid users, they know this. They know this stuff more than the doctors do. It's going to change. You're a testosteronologist. It's going to change. So testosterone cypionate, old school ester of testosterone formulated 1960s, 50s, right? First one was propionate and acetate and enanthate, right? So it came into the market 1950s. So this is old school stuff now. And the half-life of testosterone cypionate is 8 days. Now, guys, I know you're going to say it's 7 or it's 5 or 7. It's 8 days, maybe 7. You have to understand the fingerprint of the patient. This is just the standardized formulations and the pharmacokinetics when this drug was initially made many decades ago. So, but this is the drug that's used, and it's classically an intramuscular medication. But we know the world now, the new world, is using these oil esters subcutaneously. Right? Hey, doc, should I do it sub-Q or IM? It's made IM, but now we see over the course of the last 10 years, it's been going on 20 years, but with all the explosion of the TRT clinics, right? This world now that I'm in, it's amazing. So, hey, doc, is it better to use cypionate or say enanthate or even propionate or Succinone 250 subcutaneously? Those are the moderate esters, right? And with a half-life of from 3 to 4 days to maybe 7 or 8 days. Those are the drugs I just talked about. And that's what men and even women are doing to try to set up a normal distribution so it doesn't peak and trough too much. This is the microdosing. And it's really true that came into the streets from embarrassing, it's just embarrassing protocols that real doctors have been using for decades with cypionate and enanthate, where they inject this ester that has a half-life of, again, 7 to 8 days every 2 weeks to a month. That's an embarrassment. And that's what traditional doctors did. And that's where they put their own heads on the chopping block. That's not recommended now, even though it still says you can do testosterone cypionate or enanthate every 2 weeks to a month. But that doesn't make sense in the real world, because you're getting these massive ups and downs, and you're actually lowering a man's testosterone if you look at it at the nadir after 2 weeks or a month. And it's just, the guy's super moody, estrogen and testosterone is just peaking and this is just a train wreck. Okay. And that's why this whole thing has been taken into the streets with the anti-aging. And I agree with that. Cypionate. What else can I tell you? Starting dose for the average bear, not steroid using, 70 to 100 milligrams every 5 to 7 days. Doesn't mean you can't go up more. Doesn't mean you can't use less. Fingerprint medicine. So next, the clinical pearls, I would say, is it is the gold standard of TRT. It's cheap and it's easy and it's accessible in America and all over the world. The potential for high peaks and low troughs due to this half-life. Microdosing over a short interval can help with the adverse effects, but it increases the injection burden. How many guys do I see starting with anti-aging with these clinics and the TRT clinics? There's a million of them now. And that's good. I think it's good accessibility, but they're just cookie cutting and giving guys too much testosterone. And they're saying, hey, you have to do this twice a week or every day or every other day. And the truth is you can, my opinion, why would you start off doing all that injections? Now, if you need it to flatten the curve, that's okay. Most men don't. And the truth is, after 5 years, or how about 5 months, you're not going to be doing the 2 or 3 a week and 3 every day, because it gets old and it's like, doc, what's time for this? That's the sexy new toy, and then it gets tiring. And then I recommend taking it, like for me, after 35 years, I pin it every 5 days, the 100. It goes up and down to some degree, but I don't feel that's for me and 90% of my patients, because I still see patients 20 something years plus. I'm still working. Now I'm scaling, teaching. So that's the truth. Should you start with 200 milligrams a week of Cypionate at the anti-aging place? That's embarrassing because it's too much. And we're not talking about this stuff. It's not, again, it's not for muscle building. It's for your body, for your brain, for your sex, for your longevity, for your intelligence. This is what testosterone is awesome, man. But there's going to be consequences. Okay. And the compound, there's a lot of compounders, which is great. There's ability to take Cypionate or Nanthate. I know Propionate too, guys. And I know Testosterone 250 over in Europe. But when you take these esters, it's amazing that you can put them in different oil esters. Pay attention. We know that if you go to Walgreens or CVS, and I'm not putting those places down, that's like the holy grail. People love that because they can get Pfizer depot to stuff. I mean, you can get that anywhere, actually. At a compounder, they just buy it and they just give it to you. But is it in linseed oil? Is it in cottonseed oil, grapeseed, or MCT oil, or different oils? Pay attention. See, now, why would you change different oils? There's a whole host of reasons for these formulations. Because of delivery, because of skin allergies, because of sensitivities, because of inflammation. We have a lot of questions coming up. I better keep moving. Testosterone and Nanthate is next. And what I want to say about this is half-life is a little shorter than Cypionate. Otherwise, it's very similar oil ester. Again, frequency, I will say, is similar, 5 to 7 days. You can microdose Cypionate or Nanthate. Good for you. Good for you. But when you start microdosing every day or every other day, like say I do say I'm working on 200 milligrams per mil concentration in America, and say I'm going to go, all right, I'm going to take 0.5 every 5. Well, if you divide that, so that's 0.1 every day. So if it's linear, which it's not a linear equation, y equals mx plus b. Come on, guys, basic math. So if it's a linear equation, you should say, hey, every day I take 0.1. I've learned decades ago, I was like, okay, let's try it. And some guys it works. But because the oil ester has a half-life of 7 days and you're injecting on a non-linear kinetic, right, where it's non-linear. It's non-linear. Some people can be linear, but you have different breaks depending on your genetics, depending on how you're metabolizing and breaking down this ester in your body. Fascinating science. Have to go by feel, have to look at the numbers, have to look back. What are the peaks? What are the troughs? So that's how you have to understand this. But if you're taking this oil ester and you're microdosing it, most guys, if what happens is it builds up. And it's ironic, it's paradoxic. I thought I was going to microdose and get a better flat level. Sir, it's building up too much because it's building up every day, the small injections, because the half-life is 8 days. It's better to use propionate. I'm just telling you. Or maybe a Nanthate subcutaneously. I'm giving you guys, I'm feeding you guys. I'm feeding the bear here. So there's something called Zyosted. I'm talking about a Nanthate. There's an amazing draw. I wish I had one of the because I get these free the samples and stuff. So they have a patent on the delivery mechanism, which is brilliant. And I'm not selling for Zyosted. Testosterone, Zyosted is an auto-injector pen. Pay attention. It's testosterone and nanthate. And it comes in, I believe it's 50, 75, and 100. And it's subcutaneous. It's the only one on the market. You put it right into your belly. You can pick up the skin in the leg. You can really, but it's the belly. It's the sub-Q. And this, because it's sub-Q and it's going into that compartment, in theory, that it stretches it out a little bit, because sub-Q versus IM, the difference is how much blood supply. The blood supply in the intermuscular is, you have more blood supply in the IM versus the fat tissue. Aha. So in theory, again, it's theory because a lot of variables on here, and you have to kind of look at it man per man. And you when you're looking at this kinetic, is it linear, non-linear? What's the frequency? What's the dose? How much concentration? What are you doing? When are you looking at it? Peak, trough, I'm done, right? That's formulations of all these, even oral, even the transdermal. So when you look at this, you have to find your frequency. And if you want to do sub-Q, good for you. Maybe you could use less because it slows it down. The half-life is what it is, and you could kind of space it, and it sets up a regular kinetic where it's not going up and down too much. Next thing we're going to have like insulin, like pumps. You're going to put this people thought about it, like a regular pump that just continues to put it like a basal insulin pump. If you're a type 1 diabetic, they have these pumps, right? So people have already thought, hey, let's put testosterone and make a regular pump. You see these continuous glucose monitors. So what does half-life mean? Guys asking, what's half-life mean? So half-life means it's a kinetic that after a drug is how many days after injection, and it's at steady state or not steady state, half of the drug is left in the area under the curve. What does it really mean? It means that if you have a short half-life, like an oral medication that's like for blood pressure or cholesterol every day, it means that you take it every day and it's going to build up predictably, and then it will get to steady state. Doctors, nurse practitioners, pharmacology, pharmaceutical guys, pharmacists, they have to know all the stuff, because when will it get to the map? When will it concentrate? When will it deplete? How do you feel? Is it peaking, troughing? And when you're injecting oil-based drugs with half-lives of a week, and undecanate is 3 weeks or a month, you understand, if this is in the underground and the drug you're getting, you think it's a nanthate, but it's undecanate, it's no wonder it's going to be like in your system for much longer. This is why I'm opening with the formulations. Let's keep going. So half-life, sir, is the half-life of the drug, how much time it takes. So the concentration of the drug in your system is at half. That's just a standard in the industry, pharmaceutically, from decades, maybe 100 years or more. We understand that if it's short half-life, you have to dose it more, right? Like twice a day, 3 times a day, like pills. And then you look at the injections, we're dosing them once a week, twice a week, microdosing. You see? Based on the half-life. Oil ester undecanate, 30-day half-life versus cypionate, 1 week. It's literally 300 or 400% longer. So we can inject that drug theoretically in Europe and in America every 10 weeks or every 3 months, actually. But again, that's testosterone undecanate, and it goes way up and then it goes way down. So let's keep going. I know you guys got questions. Next is going to be propionate, short half-life, 2 or 3 days. Great drug in the underground because it's in and out quick. Pearls, Llewellyn's Anabolics, I think is just a great opportunity to learn more. Undecanate, so there it is. This is incredible. Half-life is, again, it's going to be about 4 weeks. And in Europe, it's called Nebido. and they load it several loading doses, and then they literally give you one shot in the glute, and it's a gram, and they do it every seasonal, every 3 months. I am not kidding. Not a great fan because it goes way up and way down, kind of like pellets. Listen to this, where when you're injecting the microdosing with cypionate and nanthate and propionate, even Sustanon 250, you could really put the finger on the pulse. You could really, guys, you feel it in the brain. You look at the number. Of course, you're looking at your red blood cells and your blood pressure and your heart. Of course, you're looking at this stuff too. And you're like, hey, I like this. Here's my peak. Here's my trough. I'm dialed in. Estrogen, DHT, hair, all this kind of stuff, mood, gyno, gynecomastia, acne. Are you on point? Are you moody? How's your erections? See, you can control this stuff better with a shorter half-life. The pellets, it's in there for months. The injection of undecanate, months. It's when's my next injection? I felt great last week. Oh, your next injection, sir? Ah, man, a month? Oh, man, I want to do an injection now. Okay, again, some men, they don't mind it. And pellets, I think, are for women. So there's a utility more for women than men. Let's go. Esters, Sustanon 250. This is the close of my injections. It's not in America. It never came here. In America in the 1960s and 70s, we had Prop, we had Enanthate and Cypionate. Boom, that's it. It was a great business, right, for Pfizer, depot testosterone. And I know there's some politics. I love to show that to you guys. It's really cool. And they kept Sustanon 250 out. Now everything's generic. It's all generic, guys. You can get the brand name, but it's all generic. And it's just the variabilities are easy to make in compounding, which is good for people. Formulation here for Sustanon 250, which I love it. But guys, if you're over in Europe or you're here and you got Sustanon 250 and it's good quality, it's 4 esters. You got the 2 short and the 2 little longer acting, right? And they theoretically go up and down. But in the end of the day, when you're at steady state, it doesn't work that way. Sustanon can really great for muscle building. But again, and it's great for TRT, but you have to use, my opinion, depending on your kinetics and who you are, you have to use less than you would with Cypionate or Enanthate. And don't forget, Sustanon 250, it's 250 milligrams per mil. All the other ones, if you're looking at Enanthate and Cypionate, at least in North America, it's 200 per mil. Guys, 200 per milliliter versus 250 per milliliter. Get your head around the math. So if I'm a 0.5 every 5 with Cypionate or Enanthate, I'm a 0.3 with Sustanon 250. You see? And then you look at the trough and how do you feel? A lot of guys will think, Enanthate and Cypionate and Sustanon 250, those are the big 3 esters of the world. That's it, hands down. Since Arnold Schwarzenegger right to today. For bodybuilding and HRT. That's just it. I don't think it's going to be eclipsed because it works. You could microdose it. It's cheap. It's accessible. Everything else is just, even Xyostat, it's too expensive. And the oral stuff I'll get to in a minute, just too expensive. Doesn't have the real feel of as the ester can get into the brain. You go by feel. And then it's got to be accessible and cheap and reasonable. Now, there's side effects on this stuff, as far as like red blood cell production and all this, but let's keep going. So next is pellets. Pellets are tough. I've never put pellets in because that's more of a procedure. I just don't do it. It's got to be done in the office. You put pellets in and they sit in there and they're going to be in there months. I got to keep moving here, 3 to 6 months. And again, they could extrude. The problem is just like undecanate, you hit a sweet spot. I feel good. And then I'm losing my sweet spot. I'm done. Okay, I'm going to keep moving. Next is there's topical. Everyone knows that. There's pumps and there's different, you can compound this. There's gels. There's creams. There's gels. You can even put the stuff on the testicle. When you put the cream when you put testosterone on the scrotum, you get an incredible conversion to DHT more than you would on standard non-scrotal T. How you like that? But some men like that because of the sex. But could you just use a DHT-derived steroid like Masteron and Primo? You guys are here to learn, right? Or Proviron or Primobolan, right? And there's other ones. So Axiron, they came up with, hey, you're putting testosterone in your skin. What if you put your little baby, your 4-year-old daughter or 9-year-old daughter or son on your shoulders? You're giving them testosterone. This is like unethical medical malpractice stuff. Delivery from a transdermal. This is like a black box warning. That's why you put it in your damn muscle. Doc, inject it. Keep it away from the children. But they came up with Axiron. It's a transdermal delivery that you put on like underarm deodorant. I'm giving you everything here. Axiron. Let's keep going. Androgen, history of putting even on the testicle patches. It's not even out there anymore. Nasal gel. There's nasal gel. I think it's limiting because it's 3 times a day. Some guy told me years ago, Doc, you gave me nasal gel. I was in a meeting, putting my nasal gel in. I was going to get fired because they thought I was a cocaine addict. Okay, I was like, oh, sir, we don't want to stop snorting your testosterone. Again, put it in the muscle and put it in your body. Okay, so Undeconate, I'm going to close with the oral, kind of a new formulation in this country. Testosterone Undeconate, super short acting, massively 2 hours versus 30 days. Just testosterone Undeconate oral versus injection. Can you imagine that? 2 hours versus 30 days. There you go. And so, I mean, I don't know. Testosterone Undeconate oral stuff, you don't like injections. You got to take it twice a day with fatty meals. I know one of the formulations, it's encapsulated in kind of a fatty material, so you need less fatty. Hoof on that. I don't even know if it's true. Men they can't even remember to take medicines for blood pressure and cholesterol. This is not going to be. This is, in my opinion, nothing can dethrone those injections. Okay, I'm done. Let's go, guys. So, are you taking patients? Yes, I am. But my patients are my priority is my testosteronologist. Please go on Testosteronology health portal and find a provider. But again, we're here for questions. Okay, I'm opening up questions. Mark, what do I do? Do I just look over?
We're going to add someone to.
We're here for questions. Okay, I'm opening up questions. Mark, is just a question. What do I do? Do I just look over? Okay, guys, here we go. We're here for questions. Okay, I'm opening up questions. Mark, it's just a question. What do I do? Do I just look over? Okay, guys. Dr. E, let's get a question, sir. Okay, I'm opening up questions. Mark, it's just a question. Can't hear Dr. E. Mark. Dr. E,
Okay.
let's get a question, sir. Dr. E, you're muted. I don't know what. Can't hear Dr. E. Mark.
Yes, can you
Mark,
hear
I
me?
don't hear it.
Mark, we got echo.
Hold on, Doc. We've got technical issue here. This is our first night on this. We're trying to work it out.
Echo.
Hold on, Doc. We've got technical issue. There's another one, Doc. Doctor, can increase my testosterone for long-term just for use HCG for 1 month? No. HCG is very short-acting. It's human chorionic gonadotropin. It's an LH analog, and it's a fertility medication for men and women. And when you inject HCG, it goes in the body, subcutaneous injection. It could be IM if you're taking a big dose, and it goes around the circulation, and it actually only stimulates the Leydig cells of the testicle, and it increases your testicle to produce endogenous testosterone. Okay. And then when your testosterone builds up in your testicle, that stimulation from the inside the intratesticular milieu, the chemistry of that stimulates actually that will inside stimulate the Sertoli cell to produce semen, but it's not as strong as using an FSH analog like HMG or gonal F. Okay, so HCG is a cheap, historically utilized, easily accessible, relatively LH analog that's injected subcutaneously IM for people, for men, for an example, women too, but it's for men that are coming off steroids or were using it. In my practice, to recover fertility. And you can take it with testosterone or without testosterone. But what is your goal? Is it fertility? Is it to maintain the testicles? This is classic stuff, right? And there's some data for it. We don't have huge trial data because it's just, there's no randomized controlled trials. It's just anecdotal. So we use HCG, but if you're using it for a short period, sir, it's only going to work when it's very short half-life. There you go, half-life. Very short, aqueous half-life, very short. And it's going to stimulate your own endogenous, your testicles to produce testosterone. Once you stop it, it goes right away within hours to days. All right, next question, Mark. So here's this guy, Mr. MR. Can we hear him, Mark?
Hi, Doc. Can you hear me? Hello?
I'm sorry, MR. Hold on, sir. We're going to, how to lower hemoglobin hematocrit. What a great question. This is one of my fundamental, this is my ABCDs. Yeah, can we get some sound on this, Mark?
Can you hear me?
I don't know why
Hello?
I can't hear him.
Hello?
For some reason, we got problems with sound here. Mark, turn off one of these. Maybe you're off one of these. But let me answer the question, MR. So you're on testosterone and your hemoglobin and hematocrit are going up, right?
Yes.
Okay. And it's potentially dangerous and your doctor or someone sees it. And if it gets to the point where it gets too high, it could be dangerous and it could lead to blood clots and hypertension and cardiac disease. Now, let me explain this to you, sir. I'm trying to dumb it down here. You're obviously not a dumb guy, but I'm trying not to talk. So here's the process. It's called androgen. These guys are going to put a headset on me. It's called androgen-induced erythrocytosis. It's called AIE. Hold on. Sir, can you speak? Can I hear you?
Yes, sir. Hi, Doc. Can you hear me?
Oh, my God. It's working. Thank you, Mark.
Yeah.
Okay.
All right.
Yeah,
So,
I've been on testosterone for 30 years.
okay. So real quick, here we go. This is Ask the Testosteronologist. You know, you're going to get these answers, but if you want more access to me and my testosteronologist, get on the damn health portal. You ask a question and then we make a video for you.
Okay.
Sir, we make a video just for you. We give it back. This is what I'm spanning it. We're taking over the world. You have to do it because I'm doing these as much as I can, but look how many people are here.
Right.
All right. Sir, real quick. How old are you?
62.
62. 30 years of testosterone?
Yes, sir. I
What
started
the
originally
savings?
with the, well, I just had surgery, so you really can't
Oh,
see.
yeah. Where are you from, sir?
Massachusetts.
Love it. All right. So, sir, here's the deal. You're on testosterone. You got to get in the health portal and do your ABCDs. The D stands for iron deposition or depletion disease. You can write it down, sir, but watch the videos, learn it. We're going to help you. Now, you're on this stuff for so long. Tell me the history of the red blood cell production. Are you being cared for by a real doctor?
Yes, I just went to a urologist yesterday.
Love it.
He wants me to see a hematologist.
Oh my God.
I tried donating blood 3 times. I got denied because my blood pressure was too high.
Okay,
I have
sir.
a lot of stress. I have a lot of stress going on, so I realize that.
Sir, listen to me, sir. This is very hard to do. It's so limited here because I don't know who you are. There's not doctor-patient relationship, but I want to help you. Sir, what is the hemoglobin? Sir, you're a smart man.
It's 18.8.
Okay, 18.8. And what is the hematocrit?
56.4.
Okay, so the upper limit normal with any urologist or real doctor is going to be theoretically 18 and 54. Sir, you just broke. Now, I'll bet you over the course of 30 years, you've been 17, 16, and now you're up. Now you're breaching because you're getting older. And if I'm gambling in Vegas, you got sleep apnea and boom, sir, you know I love you. All right. So I've been doing this for 25 years. I got to make it fun. It's the same thing over and over. I got to make it fun. Sir, you're hypertensive too. I'm scared. A, B, and C. A1C, you got to know your A1C. Blood pressure. C is the heart and the cholesterol. And then D stands for iron deposition and depletion. Your doctors are now making you phlebotomize. Look, you got to lose some weight the best you can. You got to, are you giving blood? And how much are you giving blood?
I was unable to donate blood at the time because my bottom number was over 100. I went 3 times. However, I had a doctor's appointment today. My blood pressure was 131 over 91. That's about my average normally.
Sir, how tall are you?
5'7", 200 right now.
Sir, I got to trim you. Sir, I'm not the trimmest guy in the world either. Okay. But sir, we got to get your blood pressure perfect. Come on. We're going to have a goddamn heart attack or a stroke. Yeah. Sir, I want you on blood pressure medicines. Get on telmisartan. What are you doing?
I tried. I was on lisinopril. Then I was on losartan. Then I went over to metoprolol. And then the last one I was just on was, I only lasted a week, beginning with an A. Give me 1 second. I was so tired I had to get off it. It was
side effects of
amlodipine. I couldn't even hardly get out of bed.
All right, sir. There's no free lunch on this.
Yeah.
Right now, I'm not your doctor, but you got to work through it, dude. I want your blood pressure like 120 over 80 or lower. Okay, that's you. But you gotta work with us with the health portal, with the videos. I'll make them for you, and my testos will. And then we tell your doctor we're gonna get the prescriptions in there sooner or later this year. It's kind of like self-sustained. But for now, I gotta tell you what to do. Then I'm an internist, right? I'm the boss out here. But it's like I know how to do this, but we got to lose some weight, maybe get a GLP, right? I mean, don't just get retatrutide. I mean, get tirzepatide or something, sir. Get yourself thinned down, lean out. You're on testosterone. How much you want a week? How much are we on a week?
100.
Shit. Can you believe it? You're getting older. You got sleep apnea. You're hypertensive. Sir, have you done a calcium score? Do we know it's
I don't think I've done that.
Sir, you're a bright man.
Yeah.
Get the goddamn ABCDs done. I want a calcium score for you. I want to see inside your heart at our age. Do you have plaque, atherosclerosis?
No, my heart. I just had a heart replacement 2 years ago, and my arteries and everything were good.
Wait a minute, heart replacement?
I had a mitral valve. It was a
mitral valve.
Mitral valve.
You have mitral valve regurgitation. So cardiothoracic. Do they do it through the TAVR, or they did it straight up? They opened up and went in.
Opened up.
Okay, got you. So before they did it, they did a big evaluation. They did a CT angio, and your arteries were clean.
They said everything was good on that.
2 years ago.
2 years ago.
Love it. Guys, you see this? This is real medicine. So you bought yourself some time. I want the calcium score. I still want the calcium score. It's not calcium on the goddamn lab. It's coronary artery CT It's a CAT scan of the chest. Everyone's doing it. The government, forget the government. We don't want to let me back out of the government. Hold on. The cardiology, we're going to agree on stuff, brother. Mm-hmm. Okay. But look, we're brothers from different mothers. Okay. But I got to keep moving because we have a lot of questions. I love you guys. I got to give as much info as I can. I want you to do A, B, C, D. Get on you have your own in this health portal. You have your own personal dashboard, A, B, C, D. Figure it out and fill in the blanks. Let me help you do it.
Will do.
Okay, do it. But you're back to the red blood. So get the calcium score. And if the doctor's not going to say, we're not doing that right now, sir. You had your angiogram 2 years ago. Say, calm down. Calm down, cowboy. I want to look inside my heart and see what kind of plaque I got. I'm 62. If you don't mind, I want to live to 92 and I want to kill it. Okay. So, and you want to look at your cholesterol. I'll put it all together for you.
Right.
A, B, C. How do you think I'm killing it, sir? Why do you think I'm killing it? I can't have a heart attack. I want you to say, I can't have a heart attack.
Right.
You could do it. We could do this. Okay. Now, back to the red blood cells. You got to get your iron studies. Do you know where's your ferritin? Your doctor, I love your doctor. He's a surgeon. He's not a medical doctor like me. I'm not a surgical doctor. Internal medicine, med-surg. We fight. We used to fight. We used to wrestle in the hospitals. Medicine versus surgery. I'm going to beat you up, sir.
Yeah.
Okay. So we work together. Now I'm telling you, these guys are great doctors, but they're not. They shouldn't be. Now he's sending you to a hematologist. That's a medical doctor. If you're prescribing testosterone, my opinion, that prescriber should know exactly what to do with the red blood cells, erythrocytosis. That's just my crazy opinion. I do it all myself.
Yeah.
If you
It's a
can't do it,
urologist.
what the hell? I love them. Tell them to go back to the
Yeah.
operating room and get yourself a testosteronologist. You can do whatever you want to do. I got him in
Right.
Massachusetts. We got him in New York. We got boom. Get on the damn profile. Get on the provider list and pick one yourself.
Okay.
And if they won't take you, I'll take your damn ass. But we're not talking about. I'm not looking for business. I'm looking to scale everything and teach you guys what to do. I'm pushing away business, pushing it away. You need to do it yourself. The urology guys should not be prescribing testosterone if they're going to have to use a hematologist. It's not proper.
Yeah.
You need to get so you need to figure out. I have a million videos inside the app exactly about the androgen induced erythrocytosis. It's not polycythemia vera. That's an embarrassment when the doctors call. Again, 20 years of work. I want to be respectful, but it's not polycythemia. It's erythrocytosis, and you're having a tough time with it because of multiple factors, and it's no joke, dude. But we can't make a decision on exactly what to do until we look at the CBC, which you have, which is the H&H, the hemoglobin hematocrit, platelets, and the WBCs.
Right.
Okay, not rocket science. Everyone's looking at that, and they're like, oh, shit, stop taking testosterone. I don't know, sir, phlebotomize. I can't phlebotomize because I'm hypertensive, or I can't phlebotomize because I'm over 20. My hemoglobin's over 20.
Right.
And the girls are going to say, I'm so sorry, sir. You got to go get a medical note. Look, you need to get your labs done. In this app, you can get your own labs done with no doctor's prescription.
Well, I have a bunch of labs. I just had some actually today done.
I want your ferritin, fingerprint. I want ferritin. I want iron studies and ferritin. We need to make it, God forbid, your ferritin's through the roof because you have hereditary hemochromatosis. You know, I make jokes. Can I make a joke, sir?
Absolutely.
Okay. No political stuff here, okay? You're a white man. I call it white privilege, though. I do call it white privilege. You're white privilege. If you look for Caucasian, and I love black, I love all. I don't give a shit, okay? So you look at men on testosterone. I got them all for decades. You look at a white guy from Northern European ancestry. Fact check this. Hereditary hemochromatosis. If I'm gambling in Vegas and I'm profiling you, sir, I do apologize for profiling. You're going to have, this is why you're so sensitive to it, because your genes are sensitive to hereditary hemochromatosis. And you're very sensitive to the effects of androgens, not to mention getting older, sleep apnea, and all these, and diet, and all these variables. Okay, now, African-American gentleman comes in the room. You ever hear of sickle cell?
Yep.
We're talking this is across the transcendence of anthropologic research and truth on the hemoglobin. It's got nothing to do with fucking racism.
Right.
Okay? So you look at thalassemia. Everything, these are the Goomba guy. Maybe you're a Goomba guy, and you're from Italy, and you're Southern Italian. Boom, boom, boom.
I do have some Italian in me.
I'm just throwing my stuff out there, sir. I got to make it fun. Now, look, I understand thalassemics, sickle cell carrying state, hereditary. I take this to the nth degree. This is called hematology. I'm an internist. Fascinating. But I have to understand that with your health history. You're going to understand that yourself on the health portal. All right, brother. Got the calcium score, get the blood pressure, check it twice a day. My gamble is saying, like, you're going to lean up, you're going to do the DASH diet, DASH, do the most you can. Thank God the heart's good for now. Get a calcium score. You have maybe a little telmisartan, brother. Telmisartan.
That's the only one I haven't tried yet.
Oh my God. Let's go. It's a great guy. It's a great drug for a guy like you, for men. A lot of men. It's a great combination. Little Nebivolol, but just easy as she goes. And then you're going to do your own ABCDs. And I guarantee you keep working with us, you're going to have perfect A, B, C, and D.
You're on.
It's a lot of work.
You're on.
Get in the goddamn app. I'll keep going. Nice to see you, MR.
Thank you
Next
so much.
guy.
I appreciate you. Thank you.
Thank you so much, sir. Massachusetts, let's go. What do we got next, Mark? Who do we got next?
Hey, good evening, Doc. How you doing, man?
What's going on, Chief? Where are we from?
I'm originally from Florida, currently living here in Mississippi.
Love it. I'm not going to put you down from Mississippi. I'm not going to do that to you, sir. All right, let's go, sir. You know I love it. Question. Let's go.
So my question is, I was diagnosed with hypogonadism last year, and I've been on testosterone cypionate for 45 weeks now straight. I've been injecting.
How old are you, sir? How old?
I'm 49.
49, hypogonadism, 45 weeks. I'm like, I have to think, is that like a year? Like that's less than a year. Okay.
Yeah.
This guy's going by weeks. That's interesting. Okay, let's go.
And so I've been doing 100 milligrams every Friday, once a week since then, since I started. My most recent labs that I did my labs on the 20th of April, 2 Mondays ago, and it was 72 hours post-injection, and my total testosterone came back at 1238. My endocrinologist that I'm seeing, he said that my testosterone was way too high, and he went ahead and decided to lower my dose. My concern that I brought up to him, that he seemed to be unwilling to listen to me, was that I asked if he would be okay with me splitting my dose in half and doing twice a week to see if my total testosterone would regulate better, because right now what I'm seeing is really high peaks and really high troughs.
But sir, here we go, guys. This is a fundamental. This is like a testosteronology 101. Sir, you're taking testosterone. I just opened up with a formulation talk. Okay, let's go into the formula. This is the mechanics. And unfortunately, I got to look. I'm an internal medicine doctor. You're endocrinologist. He's an internal medicine doctor. He knows more than I do about the following medical issues. Diabetes, he's the boss. I know diabetes, not like he does. Osteoporosis, he's the boss. Cushing's disease, he's the boss. Hyperparathyroid, the boss. Thyroid, the boss. Testosterone, not the boss. I own this. I got this. There's no way. He's made an egregious mistake, and I want to be respectful to him, okay? Because maybe he's going to see this and hear this. I want to respect him. He's a brother from another mother. You can't know everything. You're giving testosterone cypionate to a man, 100 milligrams intramuscular every week. Correct, right? Okay, you're on it. After 6 weeks, it's got to steady state. Based on this drug, I don't know. I'm not going to say he doesn't know this, but he doesn't understand. Go to Google, put in nadir dosing. Nadir, Nadir, is called trough dosing. We've known that these esters of testosterone, cypionate, enanthate, propionate, sustanon 250, even undecanate, okay, that they have a predictable up and down, okay? It's called pharmacokinetics. We know that testosterone, like you're doing it classically once a week, is going to go up, and the peak is going to be at, guys, this case, I'm going to do this forever. These open. Your case is an egregious mistake by that doctor. And I'm confident and I'm humble, but I'm going to explain why. You don't look at esters at the peak. We know they're going to be high. We know it. We know it's predictable. FDA knows it. This is 60 years of knowing it. So what we look at is the day of the injection, called the nadir. You should have gone to the lab on day 7.
So actually, I did get my labs done as well last Friday, and I just got my results today. And my trough, and so Friday before my injection, my trough was a total T of 460.
Let's hold on. Now, I promise this guy is not coming. He's not a setup. I've never seen this man any before in my life. He knows that. Okay, guys. Okay, this is, again, your doctor is very busy. He can't know everything. You're a very respectful man. You're going to say, doctor, you're going to go to Google AI and put cypionate dosing, nadir, trough, nadir, peak, trough, and then you're going to get a lot. Okay. You're going to say, doctor, I'm on 100 milligrams a week. My trough, my nadir, use the word nadir. That should be impressive. Nadir dosing is the standard of care. So we look at the nadir. This doesn't make this. When I heard this 20 years ago, I couldn't believe it. I was like, oh my God, this doesn't make any sense. But welcome to the no one's going to argue me. Now, if he says, oh, I'm moving too fast, I don't blah blah blah, it's not an answer. It's not the answer. Okay. If you don't know something, I don't know it. I raise my hand. I don't know it. Okay. Go over to this guy. Okay. It takes a team. 1,200. What was it on 72 hours?
1238.
Hold on. I remember 1,200 and then 400. Hold on, guys. Hold on. 1,200, 400. This is a big difference. Yeah. You're the average bear. Okay. So we don't make decisions on dose based on the peak. We know it's going to peak. And I remember and I've been telling the story lately, and it's funny because I was trained at University of Connecticut in New York, and then I went to Connecticut, trained by some of these great guys, the best guys. I mean, really, all over this world. And I remember I was in an endocrinology. We're worker bees, right? When you're a resident for 3-year residency, no joke, internal medicine, 100 hours a week. It used to be. They softened it down now. I'll never forget. We run the units, we run the medical ICUs, surgeons run the surgical. Don't kid yourself. Medical ICU and surgical ICU. There's a difference. They work in the surgery. I work in the medical. We fight in the night. Okay. So you take this, I take that, we fight. Okay. We need each other. So we run the hospitals, we run the ER, and we run with the ER guys, and we run the units, and we run the floors. And during the day, you work in doctors' offices as electives, okay? I'm in an endocrinology office adjacent to the hospital, 2002, 2003, really good endocrinologist, diabetes expert. And then I'm in there working. I'm the worker bee, right? We have to work for these guys. They're the chief. That's how it works. That's how it used to work, right? I don't get paid. I get paid by the government every month, okay? $40,000 a year, $7 an hour. That's okay. That's okay. That's how residency is. So I have to prep the patients up. So a guy comes in and I go, what are you here for, sir? Most of the guys were diabetics, right? And they had endocrinology. I'm here to get testosterone. Meanwhile, I'm a steroid guy. I'm on testosterone. I'm like, ooh, this should be interesting. I go, sir, really nice guy, probably a 60-something-year-old black guy. And I go, what's going on? So I've been on the injections with this doctor. How long? I don't know, 10 years, doctor. I go, oh, okay. Making my notes. This should be interesting. What do we do? I come in every 2 weeks. Sometimes I come in every month. And I go, really? Okay, well, let me get the doctor. So, hey, doctor, come on in. This is Mr. He goes, hi, I know who this is. And this is my resident, Dr. O'Connor. Hey, sir, Tom, Dr. O'Connor, would you like to give the injection? I would love to give injection. I had to act like I didn't know how to give injections. Right? Because why would I know how to give an injection? And I'll never forget, I said to the doctor, I gave my injection to the gentleman, and I gave a glute injection, ventral glute, and the man left. I gave him, I don't remember, it was probably 1 milliliter, and he came in every 2 weeks. The doctor didn't want the patients to inject themselves. And that's how it goes, and it still goes that way. And then the patient left. I said, doctor, let me ask you a question. Why are you injecting this man every 2 weeks with sipping? He goes, well, that's what a doctor, don't question it. We can do it every month because these esters are long acting and they go up and down, and they're really, he really didn't explain it more. I said, but doctor, doesn't the low point go really low and then the high point's really high? And he goes, no. He goes, no. And he said, Tom, Dr. O'Connor, we do it. We want to see the nadir. We want to see that low. I go, what? It's a controlled drug. You don't want to see it too high. You see? Now, that's shameful, but that's how it works. So your doctor either is not aware that you went on day 72 hour, you went on day 3. He's thinking it was day 7.
No, he actually, I told him, I was like, this is 72 hours.
You're done. So you're going to educate him. I don't want you to leave your doctor. You're going to say, doctor, I did something with O'Connor. You could show my CV, my resume. I'm respecting him, but he's wrong. Okay. You can't know everything. And you're going to say, doctor, it should be done nadir dose. And my nadir is 400. And it's only 100 every week. And I feel fine. ABCDs, right? A1C, blood pressure, D. If this guy sends you to a damn hematologist, I'm just going to eat my hat. What are we doing? I mean, this should be now. Again, great question. Did I explain it to you, sir?
Yeah, I just feel like he's just treating me to the number and not to me specifically.
Well, he's not even doing. Hold on. I'm respectful, but the truth is, and who's going to argue me? We don't look at the peak of cypionate with 100 milligrams a week on 7 days. We don't want to see what it is. And we don't. It's anyone who says that it's an embarrassment, absolute embarrassment, because we know it's going to go up and down. So what do you do if you don't like it? Cut you down and cut you down. It's an embarrassment. Even if you take 0.1, this is the nature of cypionate, of the nature of these esters. That's why they are tough. That's why they are tough. And look, and there's nothing perfect about this. So that's why guys microdose. But even when you're microdosing, you look 4 hours after injection, because sometimes you inject it depending on where and it goes into the circulation too quick. You go to the lab and it looks outrageous. I'm telling you, it's common sense on top of science. Keep the dose low. 100 milligrams every 5 to 7 days is a perfect dose for most men. Did I say every man? I said most men. You have a fingerprint. My patients, fingerprint medicine. I use the lowest dose. I try to space it out. How do you feel, brother? Are you peaking, troughing? Are you irritable? How's your sex? And then I go into your blood pressure, the ABCDs. He's not even doing that because he's too busy. He can't. The guy's going to be excellent for diabetes. Hopefully you don't have diabetes.
Yeah, you want to know the funny thing is that the lab results before that were only a difference of like 89, and he said those were perfectly fine. And then when these results came out, he's like, "That's inadequately high," as he put it.
Well, but he bring this to his attention that you went on the peak, which is day. This is a classic. This is like an academic case. The peak based on the FDA pharmacokinetics is 48 to 72 hours. I don't want to see it. It's called nadir dosing. Am I saying it over and over? Are you clear? Did you know this?
Yes, I did.
Okay. Well,
I've seen your video. I've seen plenty of your videos too. I've been watching you online.
You have my blessing, sir. But again, you have a blessing. I'm a very aggressive guy because I'm from New York. Don't get mad at me. I can't change my personality. But am I being disrespectful to the doctor?
No.
He's wrong.
No, I've lost faith in him, Mac, to be honest with you.
He's moving too fast, and he doesn't. A lot of these, I love these guys. I love these guys. You can't know everything. We've gotten to a point in our technology, you can't be a jack and all, a master of none. All I do is testosteronology. Of course, heart disease, kidney. I color tightly within the lines. And if I don't know something, hey, man, I don't know it. Go see this guy. Go see that guy. We are at a point in our world where we have an overload of technology, no shit. And it's for endocrinology, there's 7 endocrinologists now. Cardiology, 7, 10. How many guys for the eye? Oh, I do the cornea. Oh, I do retina. Can you imagine where we are? Now, testosteronology, it's a full daytime job. You could work around the clock and you still won't know everything on testosteronology, but I feel like I do. I've been doing it for 25 years, but I'm an internist and I only take care of people on testosterone. And you have to know the pharmacology. You have to have experience. You have to know each person. That's just a sad. That guy's making a wrong, because clinically you don't diagnose and you don't triage and dose when someone's at steady state cypionate at 72 hours. It's nadir. Go to Google, nadir dosing. You'll see that's what it is. Why? Because the nature of the peak and trough. And well, what about that peak? I don't know. That's just the nature of cypionate. Use propionate, or don't even do injections. That's why a lot of doctors don't do injections, because they don't want to see it. That's why they do pellets, or that's why they do gel or oral. And that to me is that's not an excuse. It's kind of a bullshit excuse, because it's like, don't go more than every week. I like it. My average patient, after 20 something years of me doing this 24/7 since 2005, after residency training, I was doing this during my residency too, though. Don't kid yourself. Inside my residency, they were letting me take care of steroid users with harm reduction. 2003, 2004. Then I graduated from the residency 2005. And I could tell you that the chiefs that I took care, the endocrine guys and the primary care guys that were all internal medicine, they were like, "Oh my God, Tom, you're going to teach us, Tom. This is scary stuff. We don't like this sipping. It looks like a steroid. So we like to use gel." But that's not right. You're thinking the doctor's treating himself, it's called. And you don't go to Google, doctor treating himself, acronym, or doctor treating himself, myth, history. You'll see that's when a doctor is making a clinical decision to protect himself in lieu of the right. And again, I'm not going to go on. I don't want to disparage this guy. I don't want him to hate me, but I'm correct. I'm right. Because it's very simple. You don't look at cypionate at the peak and make a decision on the dose for the man. You look at the trough, and then you look backward and you go, we know it's going to be higher. And when it's peaking, are you like angry? Are you moody? And then I'm telling you, then you have to start working around it. And that's why cypionate and injections are a pain in the neck. But you have to work around it man per man. This is a full day job. And that's why guys will microdose, because you're going to flatten the curve. You go by feel. How do you look? Do you want to see the peak? What would be a peak? We don't know. There's no data. Maybe 1100, because that's a normal, the upper limit of testosterone. What is it? Go to Google. 1100, even 1200. So you're oscillating from 1200 to 400. Am I right or wrong?
You're right.
Oscillating. It's a curve, sinusoidal curve, guys. It's physics. Oscillating. I don't know. You're going from like low normal or normal 400 to high normal, low normal, high normal, low normal. How are you feeling? Are you angry? Are you going to hurt someone? Are you aggressive? Are you moody? This is what I do. I have to fine tune it around you. Anyway, I'm done. The poor guy. Give the guy a break.
I appreciate the feedback, Doc.
Good talking to you, sir. Let's get the next question, Mark. That was awesome. I hope I didn't put that guy down too much. Poor doctor. These guys got to stop seeing patients if they don't know what to do. How effective are pellets? Can we get this guy on? Or did I just try to answer that? How effective are pellets? I don't like pellets. And I've learned that from my consortium of doctors and nurses on the health portal. Society. Everything's kind of reversed. The society. Pellets to me are not great. I think they could be okay for some women. And I've learned that from my testosterone. I've never given pellets because I don't like the procedure. They can extrude. You got to pump in these pellets, and then you got to say, see you later. Once you load them, I know there's loading. Guys, I know this. But I don't like, they are effective. But again, let's go to the half-life. I'm glad I opened up with the half-life formulations. So with cypionate and enanthate, cypionate, propionate, cypionate, enanthate, succinon 250. That's all the esters in the world. Undecanate, very long acting. You can control. You see the question we just had? The guy went, I'm a detailed guy. And a lot of people are not detailed. I don't give a shit. What's my number? I don't know. Is it after a week, 2 weeks, 2 days? This man, look how detailed he is. He knows peak and nadir. If you care, and the doctor is going to apologize. Doctor's going to apologize. And he may keep him. He's 100 milligrams a week. It's not. Don't look at the peak. Look at the nadir. Okay, pellets. Pellets are very effective. I just don't like them because they're stuck in there and they go, you put them in, you pump them into someone. They sit there, they can extrude out, they can get irritated. That's probably more rare if you're doing it properly. Some people just have this nature, I heard, where they just extrude the pellets. A lot of genetics, I guess. Maybe the doctor didn't, the technician doesn't know how to put them in. It's a very simple surgical procedure. It's subcutaneous, it's not rocket science, but you still have to know what to do. And then once they're in. And again, the trajectory of the drug, including the aromatization and the converting to dihydrotestosterone and all this stuff in your brain, and it's going up. It gets to a point where people go, oh, I feel good right now. I feel great the last couple of days. And then all of a sudden it's going up and then it's going down over months. It doesn't stay the same. They're going to tell you it's not possible. It's bullshit. It's not. But can it be sustainable for some people? Yes, it can. And if you don't like injections, or if you don't want to slather stuff on, or you have kids, you can't slather stuff on because you're going to slather it on the kid. Transdermal. You can fact check it. Black box warning. I've seen some horror stories on this one. So to children, and the parents didn't, the dad didn't mean to do it, but he felt bad. The kid was having erections and precocious puberty. Look that one in Google. I've seen everything. And he's like, oh my God, I feel so terrible. He almost sued the doctor. The doctor didn't tell him that warning. Moving too fast. Doctor apologized. Kid was okay. Kid cleaned up. And the guy came to me and he said, Doc, let's just put it in my muscle. Let's put it in my muscle. So guys, you want to go testosteronology.com /stage. Testosteronology.com stage for questions. So I don't like pellets. I think pellets are like undecanate injections, and they're going to be very low. I like to keep the finger on the pulse. I like the baby and the microdosing. I like what this guy did for 1 week or less. I take it 35 years, every 5 days. Sometimes I miss it, because I just forget. I miss it. And I do it on day 6 or even day 7. And I don't feel it, guys. But when I was younger, maybe I did. And there is a mindset on this. I think it's like a new toy. I think there's so many men on testosterone and women. And I'm going to cry for the children because it sounds like I'm some kind of a drama queen, but Jesus Christ, this is not good, guys. It's not good having kids taking testosterone. It's just, I got to put the foot down. If you're an adult and you know what you're doing, not to mention you need it because you're like 40, 30, I know testosterone levels are down because people are overweight. And we have horrible crap in our food chain. There's no rocket science on that. Try to clean up. Try to do the best you can. Don't drink. Don't smoke. Try to stay lean as you can. Get help with GLPs and hope you can afford it. Watch your ABCDs. And if you need testosterone, I need something. We're here for you, including women, perimenopausal and postmenopausal. I'm fighting for women. The FDA needs to give an indication. It's not political. Well, actually it is, but hopefully women are going to enjoy this, and they're on all sides of the coin here. So it's like the FDA doesn't have an indication, this is serious to me, to give women testosterone. That's wrong. Change it. They're going to do it. Men have it. And even that is so tight. They're trying to loosen that appropriately. Accessibility. I want testosterone to be accessible. And that's why I made the Testosteronology Health Portal and the Testosteronology Society. It's the highest standard of care that you could ever imagine and you could ever access. Let's get another question. What do we got, guys? Any question, guys? More questions? What's your opinion on enclomiphene as an alternative to your T? Oh, these questions are great. It's like we kind of made these up. Seems like fake questions are so good. Okay. Enclomiphene, we have to talk about clomiphene. Right hand, left hand, stereoisomerization. Medical school, pharmacology stuff. So clomiphene is first. Now, I don't know if one's a right hand and then the other one's a left hand. But remember the O.J. Simpson case? If it doesn't fit, if the glove doesn't fit, you got to acquit. So right hand, left hand. Right hand, you ever try to put a left hand glove on or a shoe? Okay. So I'm telling you, clomiphene is a stereoisomer. Let's start with clomiphene. Then we'll do enclomiphene. It came into play 50 years ago. Don't hurt me if it's 40 years ago or 60. It came in for women for fertility, okay, mainly. But women and men are very similar on this hypothalamus pituitary gonads. Women have 2 ovaries. We have 2 testicles. You can get into the religious stuff later. All right, right from the rib of Adam and all this. It's crazy. When you take clomiphene for TRT, now, remember, what is clomiphene? It's a selective estrogen receptor modulator, SERM, old school. It's remember the Octomom? Go to Google. Octomom. What was the Octomom on? Clomiphene. So she pumped out tons of eggs, and then there was enough sperm around, and then she had 8 children in the womb. I mean, come on, this is crazy. So clomiphene for men, it blocks, very, very simple, but kind of there's some arguments to like exactly, we always say, we're not sure how it works. I think we know how it works. It blocks estrogenic receptors deep in the limbic brain, in the hypothalamus animal brain, not the cerebral cortex. That's the thinking brain, the deep animal. This is animal stuff, guys. And when you block those receptors, the feedback loop with the testicle, even though we're not blocking receptors of androgen, we're blocking estrogenic receptors. But remember, testosterone and estrogen and DA, this is a very, very animalistic, deep-seated ecosystem when it comes to this biology. So when you block those receptors with this oral drug called clomiphene and enclomiphene, the body is tricked and it thinks there's some kind of a diminished circadian rhythm. That's where it really comes down to. And it doesn't know, whoa, we got to increase the output of GnRH, so gonadotropin releasing hormone. And then what happens is your pituitary in both men and women increases LH and FSH. It's fascinating. And then that circulates around, ends up finding very specialized receptors in the testicles, Leydig serotonin, and it increases your own testicles to produce endogenous, your testosterone. The injections, any other drug from the outside is called exogenous. And once you enter exogenous, you shut the system off. You see, your brain, you can't fool Mother Nature. So when you're using a SERM like clomiphene or enclomiphene, which is again, right hand, left hand stereoisomer, there's some thought that enclomiphene, it's all the rave now, right? It wasn't around 20 years ago. I don't know. It came into play maybe 7-10 years ago. And it's, probably one of the peptide, it's on a peptide site and it's in the, and I'm just having fun, guys. I mean, I'm not here to put this stuff down. I mean, I like you getting accessibility. I just want to know, like, what's the quality of it? What's the high? I want high quality stuff. Come on, not every place you're getting it from is great quality. I want that to change. Okay. So in the end of the day, the man doesn't want to jump on testosterone. Either I did the formulations, either the gel, the nasal gel, you're snorting testosterone, the pill, which is not a steroid. It's testosterone undecanate. It's out there in America. We have 3 brands. I'm not going to say the brands. And they're expensive. They work. They run through the lymphatic system. They're not hepatotoxic like Dianabol. I'm telling you, oh, they're hepatotoxic. It's embarrassing if you say that. Don't say that. Don't say it's hepatotoxic. It's an embarrassment. It's not hepatotoxic. Bro science guys. It really is irritating me. They're hepatotoxic. Oh my Lord, that's an embarrassment. Okay. So you take any of these exogenous drugs, you're putting your brain, your testicles to sleep. Good night, go to sleep, go to bed. Right? Balls shut off. Okay. So who wants that? Fertility. So it's good to consider when you're on a spectrum, you could start off with enclomiphene or clomiphene. I do it. But I tell guys, it's for guys who are like, ugh, I'm low normal. I try to lose weight. I don't want to smoke and drink. I don't want to eat. And this is not endogenous, a guy who has a pituitary adenoma, please. This is not Klinefelter's Kalman syndrome. I'm showing off. Kalman's, Klinefelter. I have all this, right? This is congenital men. It's pretty rare. I think Klinefelter's is not so rare. You could look at this. But these are regular men. They're getting older. Their T is kind of low because they're fat. It's America. Maybe you're in India. I don't know. We're all the same. The world is toxic and my testicles are poisoned. Okay, but you don't want testosterone. Let's try clomiphene. Let's try clomiphene. Yay, love it. In the end of the day, you're going to see something that's fascinating. Your testosterone levels are going to go through the unbelievable. Holy shit, it works. John, testosterone is really high. I'm going to slow this down. Doctor, it says it's that high. I don't really feel that good. That's a paradox. On paper, looks really good. Because I think, again, we have hypotheses. And this is where the bro science guys are great, right? Because we talk about this and it's real science. And doctors know this stuff too. Look, fertility guys and endocrinology guys that are in this world, not that endocrinologist that poor guy has. He's definitely not. He's going to be great at diabetes. If I'm gambling, he's not good at, he doesn't know this stuff. So can't know everything, or he's sleeping. So when you look at this fertility drug, fertility urology, endocrinology, andrology, testosteronology, or you just know this stuff, the SERMs could work in the beginning and you could maintain fertility. Your testosterone levels go up. Guys that have been exposed to steroids, it's dangerous because we don't understand why. They don't feel good. It makes them depressive and it makes them moody. And I've even, unfortunately, I've been through suicides. Again, guys, I own this because I've put my balls, if you will, in the chopping blocks for this is what I do. This is what I do. And I learned the hard way that, hey, you do steroids, we use post-cycle therapy, we put together concoctions of clomiphene, tamoxifen, AIs, and HCG. And we have other stuff, Proviron. Oh my God, I know this shit, guys. But there's no textbook except for Llewellyn. And I wrote for that textbook, okay, 20 years ago. I don't know, it was 12 years ago. No one even has books anymore. It's all here. So I like it. Sir, if you're in another country or here, you could start on that, but and it's like, what is it, 12.5 to 25 milligrams? It seems to be, and clomiphene is a little bit more potent than clomiphene. You're going to see on the internet that it's less estrogenic bullshit. There's no data for that, but it might be for you because you're using a lower dose, but then you're going to get down regulation. It doesn't work. Most guys, my average guy that I've seen come to me Doc, I've been on clomiphene again, and you could say when I say clomiphene, because I'm an old guy, you could just say and clomiphene, okay, because that's the new. But there's really much difference, and no one's going to argue me on that bullshit. Right hand, right, left hand. Okay, so when you use these drugs, you get a precipitous, you get a specific effect. And then how do your numbers look? How do you feel? Be careful, because your testicles are going to make more semen. Guys have had problems with this. They didn't realize they're fertile, and I'm on testosterone. I'm using clomiphene. I'm using gonadorelin. I'm using all this, but I'm infertile right now. And then boom, they got be careful what you do. And then a lot of guys, they think they could use this to get fertile, and that's a whole other animal, because it doesn't always work. And a lot of guys feel like shit on clomiphene and clomiphene, but the levels look good on paper, but they don't feel good because the estrogenic block in the limbic system. I'm done. Give me another question. Hope I answered the question. What do we got, guys? I'm still going.
I was asking, where do you inject, and what gauge needle?
Where do I inject? I use 25. Oh, this is a great question. I use 25 gauge needle to draw and inject. Let's go into it, guys. Everyone's so fancy now. I think a lot of the new guys are on testosterone, and it's a new toy, and it was a new toy for me way back in the day. And you look forward to it. People are like, "This is insane. You have a drug problem." I don't know if we have a drug problem. You just feel great. Okay, you inject. So when you're injecting testosterone esters, propionate, cypionate, enanthate, sustanon 250. We're not going to talk about undecanate. It's a whole other animal. It's oil. It's aqueous. Hold on. Aqueous versus non-aqueous. This is oil-based. There are aqueous old school esters, but we're not going to talk about those because those are very rare. And that's suspension, and that's painful. That's steroid stuff. But I want to cover that. So when you're injecting cypionate, never put it in the refrigerator. This is an embarrassment also. It's got to be room temperature. Matter of fact, it should be warm. Like maybe even like, I'm American, so I'm going to use Fahrenheit. Maybe 75 degrees Fahrenheit, maybe even 80. Some guys historically would put it in their pocket, and they would, what's your body temperature? 98.6. So if you can bring it to like 90 degrees Fahrenheit, it's not going to boil. Okay, it's not going to denature it. If it's warmer, it flows better. And if you're using, say, I like a 25 gauge to draw and inject. I have no time for this anymore, guys. But what do guys do? If it's cooler or even room temperature, they'll take a 21 or even an 18 gauge, and they'll draw it because it's big. That's a big barrel. And if your doctor, newbie guys, if your doctor is having you inject with a 21 or an 18 gauge, you got to run for the hills. There's the other guy, I could rehab. The other guy tonight, I can give some rehabilitation to that doctor. Just give him a break. He peak and trough. He's like, forget it. Forget it, Tom. Forget it, doctor. Now, guys giving you 18 gauge, 21 gauge, which doctors will do it, 21 gauge, and they'll say, use that, man. Inject that into your leg, your butt. Oh, that's a harpoon. That's medical malpractice. I mean, okay. So 25 gauge, I take it. You don't need, sir, to do 29 gauge pin and do. I'm just making fun of you guys. Again, it's a toy, but I like, you asked, I like a 25 gauge. I draw it. I clean everything off. I clean the legs. I inject in my leg. I used to do the deltoid. I could never get around to do the glute. I've had to have guys do the glute for me when I was back in the day, but I'm so tight that I can't get around. I could do the ventral glute. I think I've probably done it, but I just don't like it. So I love the vastus lateral. I love the leg area, but you got to be careful because if you pull too tight in, to what's called the rectus femoris, that's an area where you're going to get a lot of, that's the pain area. And it's just going to be like you have a Charlie horse. But my own wife, my dear wife, who's such a good nurse, even showed me about 10 years ago really how to give that sweet spot in the distal, right, the lateral, the down, up for the kneecap, just a sweet. I have sweet spots. And I go left, right. Again, a lot of guys, you don't, and I've been injecting for 35 years, and I don't, and some guys, hey, doc, you're injecting so much, you're going to get scar tissue. I'm not going to say that's phooey on you. I'm going to say when I inject into an area and I could feel it going through, like kind of like a rock. It's weird. It's like, oh, shit. And it's like I push through it and I inject. And I don't notice anything. It's not like it doesn't. Now, cellulitis and infections, oh my God, guys, you have to be careful. You have to understand your injection technique. So again, 25 gauge, draw and inject. Some guys like to use bigger 21, draw, switch, keep it clean, keep it sterile, put on a 27 or maybe a 29 or 30 insulin syringe and either do it IM or sub-Q. I gave you your answer. Let's keep going, guys. What level of testosterone would you consider is normal for a 6'2", 245-pound, very active 50-year-old? Oh my God, this is another great question. Let me take a drink of the mountain water. Hold on a minute. This is not booze, guys. This is Mountain Valley. Okay, so 50. How old's the guy? 50? Sir, testosterone total and free. I don't know, sir. You look at it. Let's just talk about total range. Unfortunately, too big, right? 300 to 1100, right? Nanograms per deciliter. So, a guy like you, sir, I don't know. I mean, 500. And again, this is true. Here's the standard of care. You should get the morning testosterone, morning, not the afternoon. You should be kind of rested. It should be kind of like this perfect scenario. Now, if you're a cop and you're working second, third shift, and if you're a fireman or you're exhausted or you were in Vegas, why would you come back from Vegas and get your testosterone? Okay, I just got to make jokes. So it's like, it should be like rested. You should go in the morning and they're going to do one lab. And then theoretically, you should look at that test another maybe 2 weeks later or within a month, not like back to back. I agree with the endocrine guys. I agree with them. You shouldn't just look at one number and you're done. It doesn't work. You should look at total and free to make a diagnosis. LH and FSH, again, all this information is on the health portal. 2 labs in the morning, total and free, liquid chromatography, mass spectroscopy, run-on dilution method. Come on. I mean, there's a lot going on here. You can't just look at total. You need the free. And then you also need sex hormone binding globulin and albumin, and you need globin, and you need a proper history and physical. I mean, ABCDs. Come on, sir. Okay. And then what's your number? Here's how it works. I don't know. Even if you're, sir, it's kind of hard for me because some of this stuff is kind of political and it's like, we don't have real, it's like, look, even if you're 300 or 400 and you've checked it and you're like, oh God, doc, there's a lot of variation. Like there's diurnal, there's circadian rhythm. Come on, 300, 400, and then go 500. It shouldn't go from 3 to 4 to 7 or 800. That should not happen. So, and if you're looking at the total and it's relative to the free, it's a whole other animal. And the sexually binding globulin is otherwise normal, and the quantitative and the qualitative. Okay. And then if you have no symptom, you don't look at the numbers, sir. If you're here's how I could answer this. If you're in the 400 range and you're young, but you're 50, right? That's young compared to maybe me, 62. Maybe if I'm 90, it's young. If you're in your 50s and you're really healthy, not overweight, done the best you can, drinking, smoking, ABCDs, testosterone, what it should be, 500, 700. I have to give an answer. Okay. Now go back. If you're 300 or 400, but even if you're 400 or 500, what's your free? What are your symptoms? Are you tired? How's your sex? Sex is probably the most important one. And if it's like, well, I'm not like 18 anymore. Well, do you want to be 18 anymore? I mean, there's so much independent variables, man per man. And then if you make a decision that you've crossed off all the boxes and your testosterone doesn't go up by weight loss, most of these men don't need testosterone. They need to change their behavior. But America, and I love America, we're like this. And now everyone's jumping on testosterone, and a lot of guys are going to make a mistake because you're on testosterone. And once you're on it, after a trial period of maybe, we don't know, maybe 6 months or a year, you're never going to come off. Never. And guys have come to me and said, doc, when I look back when I was 40 or 50, I jumped on testosterone either from the streets or from the gym or from all these clinics. And now it's a couple years later and they're like, man, fucking, I made a mistake. Now I can't go back. So be careful. I hammer you. I hammer. When I take a new guy in and he's a virgin, natty virgin, most 90% of my guys that come to me, they're already on testosterone and they don't want their clinic sucks. Or they don't want to have another heart attack. They want me. They want the boss, management. I don't have to make a decision because the guy's like, doc, I'm on 10 years. I just don't, my clinic sucks or my doctor doesn't know what to do. So I'm the boss and they come to me. Okay. But if I have to have a new guy, which is occasionally, I still take some new patients. But when I take a new guy and he's a natty virgin, I hammer this guy because he really has to be real to get testosterone from me. And I never give it to children. That's a goddamn truth. So, okay. So that's the truth, sir. I don't know, 500, 700, look at it twice, understand what brings it down. Go to Google, go to the health portal. What brings testosterone down? How do you fix it? Here's how you fix it. And then give it a period of time. How do you feel, sir? How do you feel? You go by, in the end, it's not just a number. The endocrine guys, they finally tapped out on that. They did tap out. It used to be, you got to be John, you got to be 299. Oh God, I'm 305. Nope. Got to be less than 300. We're beyond that now. Okay, but if you're 400, and I call it the 400 club. I got to be careful with this, right? Because I have to be regulated, right? All doctors do. So it's like, for a guy that has 400, and otherwise he's healthy, he feels good, he's happy, he's not depressed. That's a whole other animal. And his sex drive is okay, and he's okay. He doesn't need testosterone. You can even have 300. Doctor, do I need testosterone? I'm 275. I feel okay. I'm okay with this sex, and I don't want to. Do I need testosterone? Am I going to die? Absolutely no. Now, if the guy's got cardiac history and he has frank low testosterone, yeah, he could die. You have to understand history, John, is everything. History. I'm teaching history with my doctors and nurse practitioners. All these clinics, they're just boom, 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 boom. They're giving you testosterone without even testosterone number or one number. And what if you were exhausted or you're working late and I have one number, it was low. Okay, here you go. Come on, guy. That's bullshit. That's got to stop. But hey, maybe that's what guys want. Okay, let's go. Next question. Steve, what's going on, Steve? Oh, we got a guy in person now.
How's it going? I have some pretty interesting paperwork, I think.
First of all, how old are you, sir?
I'll be 43 July 1st.
43. How long on testosterone? What do you tell me? The little thumbnail sketch.
Started running SARMs when I was 35 after a lifelong max body weight, pretty much of about 150 pounds at 6'1". Basically, I went in the Army when I was 17, got injured and ended up with a groin region varicocele. And at that point, it seemed like my anabolic response to androgens fell off because I went into the army weighing 176 pounds and came out weighing 152 pounds. And then pretty much no matter what the diet, no matter what the exercise regimen, attempting to bulk, all these things, I never hit the scale at more than 156, even water loaded.
Hold on, varicocele. So I know a lot. I know all this stuff. So varicocele, that's in the land of urology, but it's also in my world. I learned a lot about varicoceles. Now, did you have a congenital varicocele from that they discovered later, or?
No, I was idiotically running a self-created gauntlet in the billets, basically gambling with a bunch of other guys, and basically in part of the way through, basically I ended up just basically nutting myself in the rails of a bunk bed system. And basically wasn't great. Ended up going to the hospital at that point, and as a result had an in-checkout diagnosis of varicocele, but basically before physically injuring myself hadn't had any issues or anything of that nature.
A congenital varicocele.
No.
That does cause fertility issues for men commonly, and then less commonly hypogonadism, but it can cause low T. So, okay, so you got the varicocele, kind of a trauma, work-related or lifestyle-related trauma.
Idiot-induced.
I love the military guy. I love you guys. So, okay, so you do that, and then you're not a steroid guy. No history of anabolics at all?
Not literally until I was 35 did I hit SARMs.
I got you. So the SARMs, a lot of people don't realize SARMs, selective androgen receptor modulator. A lot of the young guys, last 10 years or so, now it's unfortunately exploded legitimately, where they think it's safer to do RAD and Ligandrol and Osterin, right? Because, hey, man, it's selective. It's not going to shut me down, man. And then that's completely wrong, right?
That's for sure. I did essentially have a full lifestyle shift and got fully dialed in between the ages of 30 and 35, as well as essentially conducted all of my research. And then my mom has a PhD in nutrition and has written several books. And essentially, I grew up more or less watching her in the gym since I was, old enough to sit on the stool at Strength and Health in Bakersfield, California. And she's currently 62 years old and has, I would say, probably about an 8% variance in her physique than when she was 30.
She's a beast.
She's a beast. And
your stuff, you did this, you did your SARMs, and then, so bring us up to that, Steve, please.
Right. So I had good luck with the SARMs. Essentially, I felt confident enough with my research and everything else after 5 years, and then having a lifestyle shift and knowing that I was dialed in as far as diet, workout, time, commitment, consistency, everything, and had essentially purchased a variety of SARMs at least a year and a half before I even ingested the first drop. And so by 35, I knew that if I had gotten there, that I was going to be ready if I hadn't seen results based on 5 years with the money to have put into diet. I've been to culinary school, and so I know how to cook and do cook.
So you didn't jump in. You didn't jump on the bandwagon too quick, for sure.
Right. And my mom had always told me that if I had dedicated myself, that she thought that I would grow. Unfortunately, she had seen me back when I was a teenager, and I was growing based on energy output and lifestyle and things like of that nature. But after my injury, the same amount of calories and activity wasn't even near cutting it. And so when I amplified that,
Your testosterone was probably lower, right? It was probably going low, right?
Right. And so, the thing was, as I started having, it was just a low anabolic response to the androgens as opposed to overall low androgenic response to androgens.
But to your natural testosterone, you mean?
Right. Well, where I still had high sex function, large testicles. Frankly, when I hit 30, I've been in a relationship for 18 years. And I went from being very, 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 very socially rampant before that to 100% monogamous and years and years and years. Well, as I started hitting basically my 30, 31, 32, and I was exercising and having my diet all dialed in, my sex drive was starting to escalate even beyond where like it was when I was in my late teens, early 20s, because I was exceptionally healthier. And frankly, I was in such better shape that my social options were just becoming just more and more on-handly available but where it was becoming kind of intrusive psychologically to me. And it started coming to a point where my sex drive was escalating beyond what was rationally feasible within the relationship and lifestyle that I was leading, which was in all reality 100% good enough. Like it was good. And so the key thing of seeking SARMs was I was looking for something, honestly, that was going to lower my sex drive to make my life at the time more manageable. Because I didn't understand at the time that I had undiagnosed off the charts ADHD.
Okay.
And so it was causing hardcore impulse control problems.
Okay.
But because I'm very, very, very militantly self-controlled, I didn't act out on them, but it wasn't changing what was happening inside my head.
Okay, so let's get into. I want to get into the labs, though. Just for everyone listening, I just want to help.
Yeah, sure, because this is all certainly this is all applicable to the labs and everything. Because when I first, I managed to, so I ran SARMs on and off, and had I felt like good rebounds and everything, running enclomiphene and tamoxifen from the jump. I never did an improper PCT. Whether I was doing just Ostrine, well, I started out with just Ostrine, like most people do, and then went on to RAD, but only ran RAD one time because I'm already innately like hard and dense and low body fat. I got onto LGD 4033, which allowed me to, unlike a lot of people who are already just innately carrying a lot of mass who get too ballooned up, it allowed me to simply just look more normal in my clothing, honestly.
Okay, so let's go into. I just want to. You're a very bright guy, but this is, for a lot of people listening, they're like, what the hell is this guy? Because the bro science stuff is so extreme. A lot of people don't know this stuff.
Sure.
But I know a lot of guys too. I know a lot of guys too. But
right, and so I basically got on through Peter MD, one of the online medical mail things, been around for years and years, because they were prescribing and approving based on lifestyle, not based on number. So you didn't have to come in under 300 to get approval for TRT. And so my first test, I came up at 455, which wasn't, it was actually better than I thought that it was going to be.
And then you start. So how long you were on testosterone, I assume? Yeah,
for 3 years now.
Okay, 3. What are you taking? How much are you taking?
At first I was on subcutaneous 140 a week, 3 time a week injection, which was fine. And then a couple of months later, I got her to raise me to 180. And then a few months later, I got her to raise me to 210.
Okay, so and what are the questions now, Steve? I want to make sure we have enough.
So I eventually got put on oral troches, and now currently I'm on cream. So I've been through the gamut of stuff. So and my current cream is 800 milligrams a day.
But no, wait a minute. Why would they go? Why are they going from injections to cream?
So I had a provider change. Peter MD was getting expensive, basically. So I had since I already had a diagnosis, I was able to transfer that over to my standard healthcare practitioner. and get my TRT covered essentially by insurance at that point.
Okay.
Yay. So it was like free TRT. So eventually I had an insurance change and my doctor switched. So my current doctor doesn't prescribe injections at all.
Oh my Lord. Okay. So you have to take the topical. Okay.
Or the orals, which I also have. And
let's get right to the question.
So my current TRT regimen is I have 200 milligram per gram testosterone, and I do 4 grams a day, 2 in the morning and 2 at night, which is by any stretch of the imagination was considered extremely high. Right. And so the thing is, my androgen response comes back. Yes, it's over the lab core value. So it's greater than 1500 on the overall with a free of 47.7.
Right. So what's the upper range normal of the free?
It's 21.5 is the max on the free.
Right. Right. So it's definitely the 1500 blows out. It hits 1500, and if it's 1501 or 15,
you got to have mass spec. Right. You have to have mass spec after that.
It's going to be the same. So it hits 1500. Oh, done. That's it. And then the free is you're actually not that crazy up over the free, and that's in picograms per milliliter, I assume.
Yeah, picograms per milliliter is 47.7, right. And the reference range is 6.8 to 21.5.
Right. So they're not really apples to oranges, all this stuff, but it's complicated. But you have to kind of look at the number, and they don't look at the total, look at the free. Okay, so what I find to be like the most, I guess, valuable about this paperwork is that is my cholesterol numbers, my Albin and my hematocrit and things like that are essentially biologically aging me at anywhere from 8 to 19 years old. And I felt like that was going to be notable. I want to keep moving because I can't spend too much time, Steve. There's so many guys, Steve. Here's the deal. ABCDs come onto the health portal. You need to know A1C, B is blood pressure, C is cholesterol, and D stands for the iron deposition or depletion. That's your hemoglobin hematocrit. Now,
I have that right here. The hemoglobin of 15.7 and the hematocrit of 49.1.
15.7. That's not bad. There's nothing wrong with that.
Right. No, it's fantastic. And considering what my testosterone is, and I'm one of the less than 9,000 people to be prescribed Dasoxin as well, the paperwork, the blood work is remarkable.
Good for you. Good for you.
The cholesterol total is 132, HDL 54, LDL 64.
Unbelievable. There's nothing to do, Steve. You're in incredible health.
And the albumin at 4.8.
That's nothing. That doesn't mean that's a red herring. There's nothing to do. Okay. You have great health, but it's up to you. If you don't mind, I got to keep moving.
No, I just wanted you to go over this because we always see such bad blood work that comes into the folklore of everything. That I just wanted to show that you can be healthy and be on TRT.
Absolutely, but you're going to get older. You got to keep looking at it. You got to keep watching. You'll get the iron studies. Understand what A, B, C, D, S is, and do it yourself with us on the health portal.
I really appreciate you. Thank you for all your work.
Thank you so much, Steve. Keep cropping, buddy. Awesome.
Absolutely.
All right, next question, Marky. That's interesting.
Hey, how's it going, Doc?
What's going on, David?
Not a lot. I've been on TRT 2 years. I'm 51. I do 100 milligrams, broke up twice a week. And my question is, I'm going to say it wrong, somatropin, is that safe to add with that?
So a little growth hormone.
Right.
Little growth hormone. It's not really that is it safe or not safe. I don't know who you are, but so you're adding a little bit of growth hormone to a regular testosterone regimen, it seems like.
Right.
So, I mean, we have no data I'm a data guy, so it always I have to always fall back to real science and data. I love being an internal medicine doctor, so I love data. So there's no data. It's amazing. Even today, growth hormone's been around. Look, if you look for the NFL, right, and Lyle Alzado and Lovell, these crazy stories, like were these guys taking growth hormone back then? Yes, it was cadaver growth hormone.
Yeah, the
Now,
mad cow disease and all that.
Right. I mean, this is the history. I just want to use some examples, and I'm not saying he was. I don't know him. I mean, the guy's dead, obviously, and it's interesting that he blamed his brain malignancy in his short life, his death, on anabolic steroids, which is completely wrong. You know, steroids can destroy your heart and your kidneys and shut you down, cause hair loss and and red blood cells, but it doesn't cause malignancy of the brain. Okay, but that's okay. So these guys took a lot of growth hormone from cadavers. Okay, so you can fact check that and see, would that cause a malignancy with the contamination from a prion? Okay, I'm just giving you a little tidbit. So growth hormone, recombinantly produced growth hormone, that's what you have, somatropin, right? So
Right.
there's gentropin, there's. Are you getting the real stuff?
Yes, it's expensive.
Right. And I want to ask more, like who you're getting from, where you're getting. So the deal is this, I take care of a lot of professional steroid users, bodybuilders, strongmen, powerlifters, and, they're known to use polypharmacy. That means steroids plus growth hormone plus diuretic plus you name it now, right? So steroids and testosterone and a little growth hormone. Let's talk about the good and the bad. The good, we know that the anti-aging dose of growth hormone, you're going to probably do 2 IUs a day, right? 2, right? There you go. Just gambling in Vegas. So 2 IUs a day growth. You're going to do it probably 5-6 days a week, maybe 7. Maybe they're going to end up doing it 5-6 days a week, right? Take a little break. And you'll do it at night, blah, 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 all this kind of stuff, maybe twice a day if you want. And then you're going to check your IGF, right? IGF alpha, to see if your IGF goes up. Okay, and if your IGF does go up, here's how I see it. You have to think, what is IGF alpha? Well, it's a two things. It's a growth medium that's secondary downstream from the growth hormone out of the pituitary with the liver, and that's kind of it's kind of like a trophic marker. And if you go to a hematology oncology doctor, which I did, I asked this question 20 years ago. I said, Doc, what do you think? He's the cancer doctor. So that growth hormone, uncontrolled cellular growth, you know what that is? It's called cancer.
Yeah.
So, and I'm not kidding. So no one's going to ever argue me on this because I'm a data guy. If I'm in the court, you want me as an attorney. Trust me. So when you look at the data on growth hormone, you're chronically increasing IGF alpha. Okay, you can even, if you got enough money, you can buy the shit itself. Now I know pro bodybuilders that, again, they take acrylics, they take the IGF again, and it's just a crazy world. And they take 20 units a day of what you're going to take, 20, and they take insulin, and what it's going to do, just freakish. You're not going to do it. So you're doing a little baby dose and what's going to happen? So again, the good side, your skin looks pretty beautiful to me. It's going to make beautiful skin. I take a little Botox. Thank you so much, sir. Thank you so much. I don't really need the growth hormone, but it looks like I'm on growth hormone. I have good skin. I'm almost 62. So it's like skin, collagen. Is it anabolic? It's not anabolic. I want someone to come into the ring and step in here and say it's bullshit. It's not anabolic. Can it make you leaner? I'm not putting you down, but if you're overweight, what you're going to do is not going to do shit for losing weight. It's going to, if anything, it's going to give you carpal tunnel if it works, and it's going to give you edema. Edema. You're going to be puffy. I mean, you could fact check it. Even idiots, even the bro science guys are going to agree. So, but it's a dose dependent variable. I don't think it's worth it, and I'm so scared of cancer. Call me crazy.
Yeah, I am too. That's why
I don't know, dude. I don't know. I'm a weird guy. I'm scared of cancer and heart attack. I'm a weird guy. Very weird guy. Very weird guy. People seem not to care. I'm a weird guy.
Well, I mean, there's people talking about
honestly, dude, And if anything ain't gonna make, I'm gonna be funny here. If anything ain't gonna make, I shouldn't say all this stuff. I'll try to censor myself. If anything is not gonna make me smarter, I like my brain, stronger, my erections better, and more money, I don't want to take it and make me bent. So growth, unless you're taking a shit ton of the stuff and you're a pro, I don't. But again, call me crazy. And is it going to, if anything, you need a GLP. So I would switch out the growth and I would take some tirzepatide.
All right.
If you want to do it, because I want you to do your ABCDs, hemoglobin A1C, and if you take enough growth hormone, it's going to cause diabetes. I want you to fact check it. I want you to again, I'm the scare doctor all goddamn day. Yes, I am this, otherwise known O'Connor, this scare doctor. But I'm 62.
Well, I was reading about it, and it said like I'm hypothyroid.
And I'm still alive.
Too. So when I was reading about it, I got hypothyroidism. So it can, I heard that HGH can cause that to get worse, or it causes it in people too. So
right. Well, that's a whole other animal. I'm not gonna, I don't know about that. The Graves' disease and Hashimoto's thyroiditis. And it's an autoimmune condition. So, but I know their overlap. I understand with the pituitary and all that, and the thyroid. So you're on thyroid medication. You're on a little Synthroid, a little T3, T4.
yes, Synthroid, 150
Awesome.
micrograms.
Right. Do you have Hashimoto's? Do they check the antibodies on that?
No, I don't have Hashimoto. And when I was in the Army in 2008, they took out, I had nodules on my thyroid and they took it.
Wow.
So,
did you have a hot thyroid like a Graves?
no, I went in, I was gaining weight and they couldn't figure out why. And in the Army is a bad thing. So they said, let's go send you they did blood work. And I got called back in that afternoon and they said, we got to get it.
So we had some they were concerned that it was cancer. The nodules.
Came out, it wasn't. Yeah.
Right. Thank God. And it wasn't Graves, because that's the opposite. That's hyperthyroid. Welcome to internal medicine. And then now, because they did that though, because they removed some of the thyroid functionally, they depleted the knot. So they have to build you back with some T4, right?
Right.
They have to give you Synthroid. So that's okay. Mark, what happened? Okay. So what's your TSH standard?
I was trying to find my last before I got on here. I can't remember.
That's okay. I want you to I want you to ask questions on the health portal. I'm there to help. Again, I'm there to help you. And then all my testosteronologists, those that I'm selecting to work with as on the health portal with us are, they're advanced and they're smart, right? So, okay, here's the deal. So growth hormone, dude, it's not gonna, what are you looking to do? I should ask you, what is your goal?
Well, I'm trying to slim down. I'm a personal trainer too. So I get asked so much stuff and I see people doing stuff. I'm like, y'all are crazy, but
let me help you do. David, and my son's name is David, so it's very special to me. David, I could tell you this is not medical advice, but I could tell you in my heart exactly what to do. Take the growth hormone, just put it to the side. It's not going to do anything for you. You need, have you heard of GLPs?
Yeah, a lot of people are talking about retatrutide right now.
Again, retatrutide is not a drug yet, and it's unfortunately it's one of these peptides, blah blah blah, and it's like it can work great. And if you can't afford tirzepatide, get retatrutide. Get it. Just get it from a good source. And testosterone and a GLP, GIP, and glucagon called retatrutide, dude, you're gonna kill it. Done. I'm done. There's not. You're gonna lose weight. You're gonna get in great shape. You're a handsome guy. You're gonna be ripped. You're gonna feel great, and more importantly, you're gonna have a sustainable life with less potential for strokes, heart attacks, diabetes, even cancer, right? And you're gonna keep the brain good, because vascular dementia. I could scare you on this, which is go to Google. Put in dementia. How much of dementia is vascular? And you're going to see up to 50%. You know what? Versus Alzheimer's disease, which is like, oh shit, can't do nothing about it. Alzheimer's is maybe coming. Bullshit. Dementia is controllable and preventable. Half of it. Half. Go to Google, put it in. And you're going to go, holy shit, what is vascular dementia? Blood pressure, perfect. Reduces dementia. Cholesterol, perfect. I know you're not going to believe. I ain't selling nothing, sir. Okay? I'm not selling the medicines. You guys are getting so much misinformation, and I'm American, and I love you guys because I take care of cops and law enforcement and tons of military guys. I love you guys. You guys are really true heroes to me. And I love the VA system, but they suck. And you know the VA, okay, they have no reason. Why wouldn't Trump or any politician say, here's what we're going to do. We're going to go to a VA system. We're going to go outside with a big carpet. We're going to kick it open. And then at the end, when it rolls out, a red carpet, a $1 trillion check is popping out. What the fuck are they doing? I don't get it. I would be elected forever. Democrat, Republican, I'm setting the red carpet for you guys and giving the VA system more money. What are they doing? Okay. I love you guys. You gotta lose weight and get in great shape. Don't put the growth hormone to the side, dude. You're just wasting your money. Ain't gonna do nothing. Go to the gym, train hard, stay on testosterone, watch your A, B, C, Ds. Nothing. That's it. It's nothing. You're gonna do it. I mean, and when you get lean, and if you're bored and you want to try some growth, go for it. But you're not going to lose weight with 2 IUs of growth.
Right.
It's never going to work. And it's not anabolic that much. You got to take a shit ton. And you're not going to get the gurus can do whatever they want. I do have to sometimes carry arms and have guys like you help me because there's death threats. I don't care. I'm telling you the truth. Okay. I take care of the big boys and I know what they do. Okay. So you're getting the bad information. You need to get a GLP like retatrutide. I agree. I'd like to see you use tirzepatide. I don't think semaglutide. I like tirzepatide. Okay, I'm not selling for the goddamn companies. Okay,
Right.
And I wish this goddamn country would give it to people. This is ridiculous. Don't call it socialized medicine. That's bullshit. We need to access this stuff. I think Trump's trying to do it, but I'm not going to talk about it. Because you guys are the best. But it's like growth hormone, dude. No, it ain't going to do nothing for you. You got to change the GLP, retatrutide, testosterone's awesome. A, B, C, D, rock on.
I appreciate it.
All right, buddy. I want to see you again, David. Thank you so much.
Yes, sir.
All right, Marky, next guy. Am I getting tired? 2 hours I'm going. I'm a little Energizer bunny. One more question. What a great night, though, guys. I got to thank Steve. Where's Steve? Wait a minute. If you take testosterone and don't work out, will you have lean muscle mass? Love this guy. I want to see this guy. I'm just kidding. All right. If you take testosterone and don't work out, will you have lean muscle? Sir, I'm going to hurt you. It's time to hurt you. Because what are you doing? You're on testosterone and you don't want to work out? Testosterone is like a toy. Testosterone makes you want to go play with the toys. Arnold Schwarzenegger said something many years ago, and it's not putting the guy down. He said, yeah, steroids and this and that. He was trying to avoid the question. This is when he was young, like in his 40s, unbelievable, like, I don't know, all the movies and what was he, Planet Mars, whatever. And he goes, what about steroids? They got him against the wall. Steroids. He goes, steroids, how bad can they really be? It's like you take some of these drugs, steroids, and then it makes you want to go to the gym and play with the toys. Okay, so you're on testosterone, and will it cause lean muscle? Yes. Even sitting on the couch. Yes, we have studies on this. But will you get more muscle if you use testosterone and go to the gym and eat great? Come on. That's an easy one. So guys typically want to get testosterone and you can't get them out of the gym, right? But then be careful, right? Because it's a slippery slope because you want to take more and more and more, and that's called steroids. So, all right, guys, I want everyone, we have a deal for you guys. We have a deal for you guys just for today only. The first month, regularly $24.99 for access to me and all my testos and all the stuff that I know you guys need and you want. Regularly $24.99 for this time today only $9.99. And here's the code. Coupon code is LIVE $9.99. And you want to go to testosteronology.com. Testosterone. Now, guys, I know it's hard to spell. Testosterone. Drop the E-ology. Testosterone, drop the E-ology. I did come up with that, and I bought this years ago for $9 on GoDaddy, maybe 13 years ago. I was like, wow, I just bought Testosteronology. I can't believe it. I'm the world's first testosteronologist. And I sat on it for probably 10 years, and I thought, nah, can't spell it. It's too hard to spell. And I said, you know what? I think if someone could spell a little bit, even like me, you can put it in the browser, and it will probably pop up for you. All right, guys. Next week, I want to see you on. Go to the health portal. Get your questions answered by me and all my testosteronologists. You can go on the provider list and see who they are. And if you're a healthcare provider and you think you're worthy, come on board. I'm looking for a great healthcare provider all over the world. We're the largest testosterone health consortium on the face of the planet. How do I know it? Because what tier T clinic, and I'm not a tier T clinic, this is higher than that, in America, because it's only America, has all of America, most of Canada, South Africa, 2 doctors, South America, we have Australia. You won't see them all on the directory because some of them are under training, right? And we have UK, Spain, where else? Oh, I think we have someone in Denmark. We have, the nomads, the Vikings up there. We have a Viking coming on play. So love you guys so much. I could keep going on forever, but I gotta let my team go home here. Next week we're doing it again, but get on the health portal and just stay in great shape, guys. Great talking to everyone. Thank you so much.